Hi everyone. So we're going to do a quick little chapter on continuous passive motion. You don't have any competencies that go with this one, but again, it's just kind of good background to have as you move forward in your rehabilitation and modality knowledge. So continuous passive motion, or what's most commonly called CPM, are motorized devices that move one or more joints through a preset range of motion at a controlled speed. So you get to use the machine to give motion to a joint that should not maybe be doing active range of motion yet, that would need support, things like that. It's used most commonly with knee injuries. In fact, all three of my pictures down here are all knee continuous passive motion machines, but it can be used for other body parts as well. So shoulder, we have wrist, hand there. So a couple other things can be used in the hip, elbow, ankle, but again, knee is by far most often. The idea behind it is that we want to deter unwanted effects of immobilization. So try to give gentle stresses to the healing tissue. Usually post-surgical is by far the most common. It can be mechanical or manual. You could literally be sitting there and doing passive range of motion with your patient, but obviously that's time commitment and kind of stressful on you and on the patient. So the mechanical ones are what we're going to talk about. There's three types of continuous passive motion machines that are potentially out there, and so it just depends on what would be at your particular location. The free linkage, which is as if you were doing it passive motion yourself. So there's a support at the proximal and distal end of the joint. The joint itself is not supported. So this would be an example over here of the free linkage where the knee joint itself is not supported. So that's not good for unstable joints, joints that we would need that support, especially, again, kind of post-surgical. So this chart kind of takes you through some of that as well. Then you have anatomical, which is the middle, which mimics the natural movement of the involved joints and also the proximal joint usually. So that's usually best for the knee. The knee is actually supported. You can see over in the chart, it's good for joint stability, excellent control for range of motion, total range of motion, lacks a little bit on the multi-axis motion, and being as adjustable to the patient. It's a little bit harder since you have that over the joint to make sure that it's completely adjusted to the patient's needs. And then we have the non-anatomical, which allows compensatory motion and movement between the patient's extremities and the CPM carriage. So a big concern is when we're doing knee and we have this support right in the proximal tibia, which is then forcing the tibia kind of anteriorly. And that, as we know, on a post-ACL surgery potentially could be damaging because that would be doing anterior translation. So it can be, it has some benefits, but it definitely prefer in most cases, you got to find what works best for your patient. So our effects from continuous passive motion, the quote that your book uses and comes back to is that motion that is never lost need never be regained. And it is the regaining movement that is painful. So if we can maintain passive motion, it becomes easier to regain motion later. So we just talked about joint mobilizations and the need to reestablish that arthrokinematic motion in the joint and how we can use joint mobs to do that. If we never lost that to begin with, we don't have to regain that. And so the theory behind continuing passive motion is just that. So when the injured joint is kept in motion, the unwanted effects of the mobilization on the muscle, tendon, ligaments, especially articular and hyaline cartilage, the blood supply, the nerve supply, all those unwanted effects get reduced. So as the cycle between flexion and extension, again, specifically thinking knee in this case, is repeated, the change in pressures creates kind of a pumping effect. So within the joint itself. So synovial fluid, the fluid inside of your joints, gets distributed and moved around based on motion inside the joint. Your cartilage and your menisci or labrums, and those structures rely on that synovial fluid for the nutrients as well as the lubrication. And so if we lose motion, we lose nutrients to those tissues. And in these cases, a lot of times those tissues are the exact ones that we want to heal. And so that change in pressure that's created with that pumping effect circulates that synovial fluid. And that circulating fluid assists in again, giving nutrients and healing properties to that tissue. It can help remove the joint hemarthrosis that has formed, so any kind of bleeding that might be in the joint post-surgical, articular edema, so edema around the joint, and then any blood in that surrounding tissues. So the goal is really through this process to reduce the negative effects of joint immobilization, encourage collagen alignment, help maintain range of motion, enhance the tensile strength of tendons. So again, if we are letting those tissues heal with the tensile strength that they're going to need to be strong in by producing this passive motion, Wolff's Law, right? We can have kind of that enhanced tensile strength in the tendons, allografts, the skin. It's been shown to help stimulate repair of meniscal articular cartilage a lot because of that synovial fluid, where we couldn't do active range of motion yet because we need to protect that cartilage and that menisci from pressures, undue pressures. So the fluid within the capsule, there's a low pressure when the joint volume is least, and that increases with the increased joint angle. So the max pressure that we have inside the joint is at flexion, and then the weakest is usually kind of right before direct or complete extension. And so that pumping, again, circulates the synovial fluid, helps remove all that edema, helps activate anti-inflammatory mediators in the cartilage, especially meniscal cartilage. And the goal, again, as with all of our modalities, is we're trying to get someone to active activity as soon as possible. And so we want to, as soon as they're cleared from their physician, to then incorporate active range of motion as soon as practical for this patient. But again, CPM can help kind of reduce the effects of immobilization while that tissue heals until we can do something more active. So with the prolonged joint motion, we have the effects on the fluid as well as the effects on the tissue. So through that tissue movement and that stretching, we prevent range of motion from being lost. Research is kind of mixed, but there's this theory that we could have increased tensile strength. We can also decrease pain. And then over on the fluid side of things, we get those pressure waves, which circulates the synovial fluid, which also helps increase blood flow. And so we get increased nutrition and decreased hemarthrosis. So those are our main physiological effects. So what happens in the injury response process? So for range of motion, research has shown that when given free rein to control the range of motion, so if patients could set their range of motion standards on the CPM machine to their comfort, they increase their range of motion by 6 to 7 degrees per day. There was more effect in increasing range of motion caused by soft tissue restrictions than static stretching. So we see more range of motion being increased CPM versus static stretching. And then the total end range time, so the time we spend in kind of the end range of flexion, end range of extension, the longer time spent at those terminal range of motion also seem to increase range of motion. For joint nutrition, it's thought to stimulate the circulation of synovial fluids, like we said, meniscal cartilage to increase the uptake of its nutrients. By circulating that synovial fluid, cartilage can heal and heal faster. It can be accelerated. We get more type 2 collagen, but intraoperative inspection doesn't really support those findings in research right now. Edema reduction, so the effectiveness is not clearly understood. It seems to be based on body part and the condition that was treated. But one study did find significant edema reduction after arthroplast of the knee and the ankle, after ACL, or I should say several studies found after knee and ankle, after ACL surgery, for knee inflammatory conditions, and hand edema has all had case studies or clinical trials that show significant edema reduction. As far as pain reduction goes, it should not be used as an acute pain control. This is not in replacement of medications or e-stim, where we get more of those significant pain controls, even cryotherapy. We do get potentially some side effects for pain, right? Primary pain relief by the fact that we can remove some of that edema, that we reestablish the range of motion. So all those things that would potentially cause pain are being eliminated in the long run. So reduction of edema could be primary. The deterrence of the functional shortening would also aid in limiting pain. And then on the secondary side of things, we are activating the joint. So we activate those afferent nerves that are around the muscle, joints, and skin, and that possibly gives us a little bit of gait mechanism, right? So same thing, when you hit your elbow, you kind of sit there and bend it and move it to help with your pain. That would be the same idea with the CPM. Ligament healing. The early use of the CPM promotes healing, often more so than surgical correction, when the single ligament is involved and there's little rotational. So it's not great with corner posterior lateral instability or anterior lateral instability or anterior medial or posterior medial where there's a significant rotational injury involved, because the plane of motion that you do is singular planar. But CPM application post ACL surgery has shown some physiological benefits, but it's not as promising as with other conditions. So again, the meniscal and the cartilage surgeries seem to do even better than an ACL surgery does. The ACL doesn't receive the same nutritional benefits that the meniscal or the articular cartilage would. And the ACL kind of has its own synovial lining, it's interarticular, but extracapsular. And so it has its own synovial lining, and it shields the ligament from gaining any nutrition from the rest of the joint's synovial fluid. And so we don't see the benefits post ACL like we would see with meniscal and with cartilage injuries.